Good afternoon, everybody. Are you able to hear me, Dr. Rahman?
Yes.
Okay, we can go ahead and get started. I just wanted to thank everyone for joining us. My name is Caroline Bowers, and I'm the program manager for the Texas Telehealth Resource Center. I'm pleased to introduce Dr. Rahman, Professor of Surgical Oncology Research at T2HSC and founding director of the Breast Center of Excellence. So I'll now hand it over to her to kick off her presentation.
Hi. We're going to talk about the resource for cancer screening in West Texas area, but I wanted to title it on purpose as Partners in Justice because we want to make sure that we cover the principles of ethics as well for this CME credit related stuff. So, which is very in line with with what I want to talk about. So, basically, we're going to discuss cancer screening deep in the heart of Texas. Now, as we all know, the from the Belmont report that the principles of ethics that apply to medicine and healthcare delivery at large, and of course, it's just as pertinent to cancer screening, has four pillars that we talk about: beneficence, which is doing good; non-maleficence is do no harm; and patients' right to make a decision about their healthcare, which is autonomy; and justice. Justice seems to offer a little bit complex thought process, and that's the focus of our program as to what really justice is in terms of delivery of healthcare. So the way it's defined is fair, equitable, and appropriate treatment of persons. Now, that leads a lot of thought process as to what's fair, what's equitable, how do we decide equity, with which metric we use. And that gave rise to this terminology called distributive justice, which is fair, equitable, and appropriate distribution of healthcare resources. Now, there's an added terminology there: healthcare resources determined by justified norms of social cooperation. Again, as you can imagine, justified norms of social cooperation can differ from place to place, cultures to cultures, or what's acceptable, especially when sometimes what we feel particularly justified. And as for example, we see these days there's a debate about vaccines. So a group might feel very justified in mandating certain vaccines, but how does that interact with autonomy, for example, where patient has a right to decide to take or not to take a certain treatment that's been offered? And so what those norms are and how do they impact? The reason I bring it up in today's discussion, which is pertinent to cancer screening, is because I wanted people to think about when we say distributive justice in cancer screening, particularly Texas, is specifically in West Texas area. What are we talking? How do we distribute those resources? What metric? Equal share? Is it according to need? And who decides the need? Does the community decide who needs what more? Or it's according to effort? Does the patient who seeks out healthcare, seeks out resources, goes to internet, does the research deserve more than the patient who may choose not to do all those things? Is it some merit criteria that we need to require, or we leave it to free market, or according to their contribution back to the society? So you can tell that there is a lot that goes into thinking how best to distribute resources for us where we feel comfortable that we are offering care with alignment of the principle of justice. Now, that leads to this another concept I'm going to introduce as medically underserved area. As you saw on the previous slide, that we were talking about, is it according to merit, or is it according to need? So Health and Human Services has developed over a lot of research and over a lot of years an index of medical underservice, which is calculated for each county or a group of people or a certain population. And the score is ranging from 0 to 100. And as you can see here, anything with a score of 62 or below is qualified by their criteria as medically underserved population or medically underserved area, which could be counties in actually our today's discussion. So how do we decide what's medically underserved, i.e., the interpretation is that populations that are designated medically underserved may be the ones that should be the target for distributive justice in terms of our efforts as providers to make sure those resources are available to them. That's why I'm delving into this. So there are lots of criteria. Provider per 100,000 population is the big one, which is very relevant in West Texas because population is sparse and distributed over wide swaths of land. Percentage of population at 100% of or below of federal poverty level, a percentage of population age 65 and over, which is very relevant to cancer screening because cancer is primarily a disease of aging, although we see a lot of young cancers as well. But you can imagine that areas and counties where distribution of older population is a bigger group that may suffer more with lack of healthcare resources in terms of cancer screening. So those things are given some points, and infant mortality rate is also calculated in it. And all those points are added to give you a score of whatever the score might be out of 100. So as we look into the West Texas area, now the red outline that you see is the target area that we are going to offer our programs in Council of Government 1, 2, 7, and 9. And I'm going to talk a little bit more about that. But this is a map that I borrowed from the Cancer Prevention and Research Institute's website, of Texas website, CPRIT's website, where they have funded prevention projects where screenings are offered for cancers. Now, the top cancers that they're targeting are breast, colorectal, cervix, and there's some lung cancer guidelines as well. But if you look at the lighter the blue or closer to gray you are, there are fewer projects that are funded in those areas. So you can see that you don't see any dark blue in West Texas. So that's right off the bat that catches your eye. What I did on this map is I superimposed with the teal little circles right here, which were the designated medically underserved areas that we just talked about. So when you look at all these are 36 counties out of our target areas in these regions that not only have fewer funded projects, but also are designated by the HHS scoring system as medically underserved. So clearly, there's homework to be done in the area of distributive justice for West Texas in terms of cancer screening. Now, the question is why and what cancers we are talking about. Now, the top priority cancers for CPRIT based on the data are breast, cervix, and colorectal cancer. If you look at the bottom row here, the Texas average of incidence and mortality is given. Now, interestingly enough, the panhandle of Texas is actually lower than average mortality and incidence. Now, I would say that there is some contribution of our program that has led to that because that's the most mature program of our breast cancer screening and community outreach in the panhandle. That program has been active since 2010. But overall, if you look at especially the mortality of cervical cancer, that's really, really concerning. And that's the cancer of relatively younger age group where the mortality is much higher than the state average. And so is the incidence. So a lot has to be said about HPV vaccinations and pap smear screenings. Similarly, we see in colorectal cancers that some of our uh, areas are much higher incidence compared to the state average and very high mortality as well. So that obviously brings to a point that something needs to be done in those high prevalent cancer areas. Now, to just go over the screening guidelines as to why those um, programs should be targeted is because of the high prevalence. There is a lot of robust and validated evidence to screen these people. So if you look at breast cancer screening guidelines, they have gone through in maybe last decade or so a lot of controversies, but I just wanted to make sure to use this opportunity to explain to people that what we use American College of Radiology guidelines, even though there is some discrepancy between different organizations, but the most validated, in my opinion, and with most robust evidence is the American College of, of Radiology and Society of Breast Imaging guidelines. And those dictate that all women should have at least an assessment of their risk by the age 30, which means the primary care physicians or advanced practitioners, whoever they are seeing for their regular health care, should have asked questions about their ethnicity, their family history, prior biopsies, or any symptoms they might have to assess their risk. But mammography should be offered at age 40 to all women because that's the only guideline that has most robustly documented the drop in the mortality rate with breast cancer because they're diagnosed at earlier stage, they're easy to cure, and there are better options for these women when they're screen detected cancers. Age at stop screening is a little bit more I won't say controversial, but a little bit less validated because these trials were old and life expectancies were lower. So trials didn't go all the way to how many survivors we see of longevity these days. However, the recommendation is that if general health status dictates that the patient's anticipated to live another 10 years, we should continue to offer annual screenings to these women. So these are every year starting at the age of 40 until the comorbidities limit the life expectancy. And these benefits should be considered along with the possibility of recall because if something is abnormal on the mammogram, then the patient may have some additional imaging, some diagnostic workup. There may be recommendation for biopsies if something is suspicious, but everything that's suspicious doesn't turn out to be cancer. So all these risks and benefits can be discussed. Now, the good news is that in today's technology, we have a lot of opportunities for telemedicine, televisits. So people who are in these areas, medically underserved areas where there are fewer providers or their driving distances are very long distances for them to travel, there can be easily arranged telemedicine appointment, and Texas Tech definitely offers those opportunity for these women as well as for the physicians that may be there in the local communities to have consults, second opinion, or discussions about these recalls and benign biopsies if need be. So that can be leveraged to provide adequate and well informed care close to home for the patients. Now, the other one is the cervix cancer. Cervix cancer is actually a very big problem in West Texas. There is there was a lot of I want to say that there is a lot of some misconception, and there are deeply rooted values and cultural aspects to screening for cervical cancer because HPV largely has been a sexually transmitted disease. So many people have religious and cultural belief system around talking about cervical cancer or prevention. Uptake of HPV vaccination has been very low. We've worked very hard and continue to work hard into changing the narrative that this is not a judgment call on somebody's personal life choices. The HPV vaccination is about prevention of cancer. And we've seen some shift in that, some relaxation in the communities in terms of accepting the HPV vaccinations for that reason. I'm sure that you guys have seen commercials on televisions as public service announcements as well. But there is a lot of work to be done. As I showed you, the prevalence and mortality of cervical cancer in the target area that we just mapped out is still very high, and we have a long way to go. The other concerning part about cervical cancer is the screening piece that pap smears are needing to be done as a procedure performed by a provider. So if you are in a medically underserved area, you can imagine if there are not enough providers or providers that are there may not be trained to perform pap smears, that poses another barrier and challenge for us to do. There is some research and a lot of work going on about one of those home based test kits that patients can perform themselves. There is some promising data have come out of MD Anderson, I believe, but it's still not validated to be generalized use yet. But that would definitely be helpful. in that area. But for now, the cytology alone is recommended for 21 to 29 years of age every 3 years, and 30 and onwards, it's every 5 years um, of cytology and HPV co-testing. So that is what's recommended at this point. And after 65, it's not recommended to continue to screen. So if you have three negative cytology results last three tests, then you can stop screening at the age of 65. Now, there is some confusion that I get asked by patients who have had hysterectomy. Now, partial hysterectomy actually retains the cervix within the patient, so you still need screening. But if there's total hysterectomy where cervix was removed, obviously the screening is not recommended for those purposes. So that is just something to understand for the providers and community health workers so they can answer questions and educate their community accordingly. Then we come to colon and rectum cancer. And of course, the issue with colon rectum cancer is colonoscopy has been the widely recommended screening test, but it's very involved, provider, facility. It's a fairly invasive approach. However, if a normal colonoscopy results from a screening, then you're good to go for another 10 years. So there is a plus and minus to it. However, you can see the access issue with colonoscopy. So ever since that we have now have fecal immunochemical tests for screening that can be done at home, that has been really helpful. Now, the FIT test, as opposed to colonoscopy, has to be done every year. And if the FIT is abnormal, that doesn't automatically mean cancer. That means that you do need a follow up colonoscopy. The advantage of FIT is you can imagine it can be mailed to the patient's home and people can just test it themselves, mail it back to wherever. And the other advantage is that if your fit is normal, you can omit colonoscopy. So it just filters out patients who will actually need colonoscopy. So if there is a dearth of providers, then you can basically distribute care according to need as opposed to everybody. So for our program, we actually use the stool-based test called FIT test. Now, Cologuard and FIT, there are some differences in that, but we're using FIT test to look at the multi-target stool DNA uh, to figure out if there is any abnormality. If FIT test is positive, we still recommend colonoscopy and offer those to these patients who may test positive. All abnormal results from non-colonoscopy screening, whether it's FIT, whether it's Cologuard or Ocker blood, need to be followed up with a colonoscopy, which is what we propose and cover in our program. So I've said a lot about our program. So we're talking today about two programs that Texas Tech offers. One is the Access to Breast and Cervical Care for West Texas, which is we call it ABC for WT program, covering the Council of Governments District 1, 2, 7, and 9. This is a very mature program. We started with COG 1 in 2010 and added cervical screening in 14 and expanded in 7 and 9 lately. Our fecal immunotesting, which is a FIT stop program, is right now only in COG 2. Dr. Obahari is actually offering the similar program for the Panhandle. But so it's available in Panhandle, but that's not this group's program. Our program is called FIT Stop, and it's available in COG 2 that we are offering FIT test. And of course, if the FIT test is abnormal, we will cover the colonoscopy and further workup. Now, how our program functions is depicted in this chart. If you can see, so we have service providers. What we have done at Tech is identified providers possibly available in these different counties that I showed you on a map and see that if they're willing to partner with us, we have contracts with them. So we have contracts with 7 hospitals in Panhandle, 2 in South Plains, 2 in Abilene area, and 4 in Odessa area. So, and we also have contracts with mobile health units, mobile mammography units, and several pap smear clinics and several health departments who offer HPV vaccinations. So when we have these partners, how that works is that we also have partnership with community organizations who may be engaged in community outreach and teaching. These are typically grassroots organizations that have volunteers, and they go out and carry out different health fair events and talk to kids in school or maybe in um, places of work, or create events, annual events for community outreach. And so we work with them to make sure the word gets out of the resource available and also the accurate screening guidelines so that the misconceptions are kind of removed. And then we have community venues for outreach. So we will reach out to local businesses, grocery stores, meat packing plants, depending on where we are. We have lots of places where we have done these outreach events to offer these services to people. The way it works is at the back end within the Texas Tech system, we communicate, and it's my responsibility as a PI to make sure that all these partners are on the same page so that these services are offered and then delivered appropriately, and the service providers are reimbursed appropriately. How we achieve that is this is a very engaged kind of a flow chart. I would say it's a process map. So we have broken it down to three-step process for every step. So for example, an outreach event, somebody may have a healthcare event someplace. You may call me and say, oh, we are having an event in, Eastland County, let's say, for example. So my team will identify our outreach workers as designated for that county and say, okay, this is the event. Let's go. If there is a booth or whatever the situation is, we want to be present there. At that event, what will happen is that we'll have a three-step process, which is what we call get educated, get qualified, get scheduled. So, get educated is that our outreach workers who are very well versed in the screening guidelines will be talking to these community members that come to the booth or reach out to them via phone or something else, or it's an event that I use the word event relatively loosely. Sometimes somebody may have looked at our flyer and picked up the phone and called us. That technically is an event. So we will educate them about the guidelines on screening on these cancers. And let's say that they qualify in terms of clinically the screening is indicated, and B, they don't have health insurance or have access issues, and so they need to be, even if they have insurance, we can still schedule them. But by qualified, we mean to confirm that if they don't have insurance, we make sure that they live in the county and their address that we know, so that we can use grant funds to support their screening. And then the third step is our partnership at the site of an event with a provider that's close to the patient's home, so that that screening is scheduled. So that screening is scheduled, and then the patient can go back home. At the back end, we make sure that every screening that we schedule, that we get the results obtained, because if there is an abnormality, we need to follow up on it and make sure that the patient's taken care of accordingly. That piece is very important because treatment of identified cancer is not covered by grant funds. However, our commitment to the sponsor, which is CPRIT in this case, is that we will look at all the resources available and financial counseling that we offer to make sure the patient's still treated. Because grant or no grant, these patients exist, and when they show up in the ER with advanced cancer, we still treat them regardless. So it's actually cheaper on the healthcare system at large if they're found early, and then we can see if they qualify for Medicaid. We can see if they qualify for local philanthropic funds, or our financial counselors can work with them to get some sort of coverage and insurance to be able to treat the cancer that was diagnosed as a result of screening. That's usually our continuum of care, which is the step two of process maps. That happens usually behind the scenes, that we identify, because each report is evaluated by the team and ultimately by myself. And if the report is abnormal, then we work on appropriate referrals, which providers these patients need to see and then get treated. That happens at the university levels, and sometimes that involves travel as well. Then completely behind the scenes is the business aspect, which is service reimbursement. So the provider at the local community and the local county, whichever provider performed the services, since they already have contracts with us, they'll generate a bill and we will get the bill. As we get the bill, our way of ensuring is to close the service loop, is to actually make sure that the bill we are receiving is is basically associated with the results that we already got. Like if I get a bill on a person that I have no clue what the mammogram shows, then we have to hold that bill on till we work with the provider to make sure we get the results. So we close the service loop. That's our stopgap mechanism to make sure that patients don't fall through cracks. Once we can match up the bill with the service provided and the fact that we evaluated the report, we honor that bill and process payment through the Texas Tech accounting system through our contracts with the providers, and CPRIT grant funds pay for it. Then, excuse me, then the other part is the stewardship of all of this. Obviously, when state gives you grant funds, we have to make sure that we are good stewards of it. So what we do from a stewardship perspective is communicate, such as this webinar. I make sure that providers understands, the outreach team understands that we are all on the same page. If there is any change in guidelines, any new evidence that comes out, that we meet. Our grassroots team actually meets every week, but our partners annual partners meeting is a big meeting that we do once a year, so that everybody can talk about what process is working for them, what's not working for them, and how can we improve. So we review guidelines, we review controversies, we adjust our process map as any changes are needed. And then of course we track the outcome measures. We generate reports to see if the patients were treated timely, if they were offered the right drugs, and all those sort of things. And then we provide feedback to our providers accordingly. And the last piece is the fiscal responsibility, which is where the quality assurance comes in, where our Office of Sponsored Programs is very heavily involved in the financial services report that's generated as to how the funds are used. That oversight is provided by the program director, which will be me in this case, as well as the Office of Sponsored Program. We work very closely together and we submit the report every quarter to CPRIT, and then usually there is an annual audit as well. So that's how both these programs work. Now, this is just an important slide, since I told you the breast program is the oldest, most mature program, cervix is the second, and so you won't see colorectal data on here because that's the youngest program we have. But since um, 2010 to about March of this year, we have provided about 11,000 over 11,000 screening mammogram services, and right about over 2,000 pap smear services. Now, pap smear is not every year, so you can imagine that that number will be smaller. We have found 214 cancers or precursor lesions and provided just shy of 9,000 vaccinations due to this. But the most important thing is, look at our contacts. We've literally, direct contacts means somebody spoke to an individual. 50,000 direct contacts. And of course, through social media and stuff, we have over 6 million contacts as well to basically spread the word about our program. But the most prideful thing I want to tell this group is our 100% follow-up care according to the NCCN guidelines on any cancer and high-risk lesion that we've identified. We've not had one situation where we were not able to provide the care, even though the cancer treatment is not covered by grant funding. There's lots of resources within the community and federally that we can leverage to make sure the patient gets right treatment. So we are very proud of that fact as well. So basically, our program is kind of robust. If you look at the whole evaluation mechanism of the program, we look at the situation first that I briefly described in the beginning, is that breast and cervical cancer have much higher mortality in these areas, barring for COG1, which I think we've impacted significantly. That's not disputable. The late stage of diagnosis remains a problem, and we know that. And we also know that socioeconomic differences in cancer and survival is quite evident. People who have these barriers tend to fare not so well in the eventual outcome of cancers. There are cultural beliefs, socioeconomic situations, emotional barriers towards cancer screening that we are all aware of. But lack of awareness regarding screening is also a problem. Education is a problem, and shortage of primary care providers, as I showed you, the MUA counties in our region. So that's the situation. So what CPRIT decided is their funding priorities were to increase the awareness and access through the outreach. And we now want to specifically target the counties that are designated as MUA counties in these regions, utilize evidence-based guidelines for screening that I just reviewed with everybody. And then based on that, our priority is to increase early detection and diagnosis, provide appropriate navigation for therapy, and then create sustainable strategies. So even when the grant funding cycle finishes, we want the community to have enough awareness and enough knowledge of the screening and the potential resources available that it does move the bar a little bit towards screening. So the inputs we have is our resources that we have collaborative expertise between the academic, public, and private partnership that we have talked about before in that chart that I showed you about lots of local businesses, grassroots organizations, and local providers that Texas Tech has partnered with. And as a large university footprint, we can provide expertise of managing those large collaboratives. Then our mass media campaign infrastructure is also helpful, especially with the Texla infrastructure that can really be leveraged in terms of telemedicine appointments and in terms of second opinions, in terms of any questions that providers in rural areas may have about the access or care to a particular patient, that can be available. And then we have WISE curriculum, which was developed many years ago, called Women Inspiring, Serving, and Educating. And we have developed a sixth grade reading level curriculum. So we can basically, if a provider in their community offers a volunteer from their practice or from their community, we can easily train them, give them the slide deck and curriculum so they can go out in their community and perform outreach for us. Based on that, we have outreach budgets and administrative staff and volunteers and those community events that are established long-standing events, plus newer events can be created out of that. So those training expertise provided the inputs for these programs. And our outputs have been all these activities that we train the outreach workers, we develop events on our calendars. We are going to do that more specifically targeting the underserved areas, and develop culturally sensitive social and traditional media campaign. I can give you an example that we ran into that situation. For example, in Amarillo area where there was a large Somali refugee community, very different cultural values. It was very interesting. The first time that I was doing events to talk about mammogram screening and importance of early detection of breast cancer with men, because in that particular culture, men would they vet the information first. So we had to reach out to men, and if they agreed or allowed us to talk to their women, then only we could access the women. So we had to kind of accommodate for those cultural nuances, and it took us a while to gain the trust of the community and be able to offer services to them. And based on all those activities, we maintain our quarterly and annual partner meetings, reports, and feedback and adjust accordingly. And the goal is to then effect policy and system change for sustainability. For example, until about, I want to say 5, 6 years ago, we had social workers that would help cancer patients who would come through the clinic, but we really didn't have a robust program of financial navigation. I wasn't even aware up to a decade ago that there is a special certification program for financial navigations, and these people are really valuable and trained on all the resources available and all the potential ways to make the out of pocket cost as low as possible for the patient who may have expensive chemotherapy and other treatments. So, that to me is a systems change that we invested in our people and got them certified and hired financial navigators. And now it's an important aspect of the cancer care programs for us. Then we have some lead indicators. Obviously, the long-term outcome of cancer screening is going to take decades before we see mortality come down. Long-term survival data probably would outlast my career. But we have lead indicators is like I showed you in that numbers chart about how many people that have we reached so far, how many direct contacts we have created, um, and how many people regularly attended those events and how many screenings we have offered. Assumption is that those lead indicators will eventually lead to the lag indicators, which we'll see later. So far, I can tell you the short-term impact that we've seen and published on is increase in knowledge about the breast and cervical cancer screening amongst lay public in the target region. We have shown the number of new enrollees from the target region into screening program. These are the people who've never had screening before and got screened because of our outreach programs. Number of early stage cancers that we diagnosed or precancerous lesions that we diagnosed. And of course, we maintain quarterly reports of all those feedbacks and provide feedback for the change again. Medium term impact would be the proportion of early stage cancer. So we want to shift the cycle of the cancer treatment to more early stage because of enhanced screening. And of course, the non tangible is increased trust between community and healthcare system and increase in volunteerism that we see, which I think is an indication of trust between the system and the community and some policy change. Now, long-term impact we expect is to cause increased survival. The important part is that we put that program together with some assumptions. The assumption is that mass media and culturally sensitive campaign and leveraging telemedicine and the opportunities such as the current one like webinars, uh, county level educational events by trained personnel and the ability to offer no cost screening to target audience will change knowledge, attitude, and practices towards breast and cervical cancer screening and prevention. And when I say change knowledge and attitude, I'm talking both the recipient community and the healthcare providers. The more the providers are aware of resources available, the more likely they are to offer those screening services to patients. I can understand the emotional toll it takes on a provider to have to talk about screening of cancer when they know that they don't have funds to support it. It will just create anxiety. So sometimes those discussions never happen. But if they're aware of the resources available, we feel that it's more likely that those discussions and referrals would happen. However, there are some external factors which we can't exactly control, that which screening services are available close to home in which counties, particularly in the underserved designated areas, and some deeply ingrained cultural perspective and beliefs about cancer screening and prevention, like we're struggling sometimes with the cervical cancer. Those will take long time to change the community's perception, but the more we keep at it in terms of awareness campaigns and constantly talking to women and children about it, even in school. I believe, for example, sex ed happens in school. It's been a normal part of education for a long time, but HPV prevention piece probably could use a little bit more boost at that level as well. And to evaluate this entire process, we basically have quantitative indicators so that we know we maintain a very accurate database of every person we screen and what the outcome of screening was. And then qualitative, when we do our partners meeting, we look at hits and misses, what worked well, what didn't work well. That process chart that I showed you has been developed over the years with several of these inputs of hits and misses as to what works better. And then we take minutes when we meet to make sure if further adjustments need to happen. Overall outcome evaluation is county specific screening and navigation numbers for individual and services that we get out of our database. So that's probably what I had to say, and I'm going to leave about 15 minutes or so for questions and answers. But before we move on to that, I'm going to do a call for action um, for that region. If you are a provider or a volunteer or a community member practicing in these areas, then connect with the step one of our process. You don't have to do the entire process map. We take care of it at the back end. But our step one process is to get on, so you can just pick up the phone, and I'm going to share some contacts here in a minute to either we want to schedule an event, or it may be about a particular patient that needs a screening, get educated, and then we will make sure that the patient gets qualified and gets scheduled to the closest provider for screening services. And that's what I'm hoping to get out of this. Now, this may require just picking up the phone. Sometimes you may want to create a telemedicine appointment, and or sometimes you might have a community event that you may want us to man the event and come and be there. Any of those things are possible and doable. Now, how you would go about doing it is depending on where you are. These are the contact numbers. I'm going to let that so that people can take it down, make notes if they want to for a minute. So we have an identified person in each of those Council of Government districts where you can reach them via email or via phone number for whatever you may need in terms of these programs being offered in that community. So we could technically help out. And this is the last slide, which is the basically to claim the CME credit for today's session. That's the activity code. I believe you can just do that by just scanning the QR code. And I'm going to stop talking and get to the question answers.
We can wait a few minutes and see if we have any questions come in, but I just wanted to say thank you, Dr. Rahman, and thank you everyone for joining. And then I might have you put that slide back up just in case anybody wasn't able to
The last one?
in that QR code. Yeah, just because it was only up for a few seconds.
Is it, am I sharing now or not?
No.
Okay, hang on one second.
Oh, it looks like.
Share. And
There we go.
okay.
Perfect. Thank you. And we can just wait a few more minutes if you have any questions.
Yeah, I don't know that that all participants are from rural areas or not, but I'm pretty sure that in West Texas, even if you yourself are not located in a rural area, we do see a lot of patients who drive up from rural areas, and I think the more we spread the word, the farther the reach would be.
Hey, Dr. Rahman, I would just like to thank you for doing this presentation on your separate funded resources for screening for colorectal, breast, and cervical cancer. You know, this is a big burden in our community, and I just like to make sure we get, an introduction with Caroline and Kelly. You know, they're with Texla TRC, and they have this partnership with NOSOR. NOSOR is the National Organization of State Offices of Rural Health, and I think in November 20, it will be a National Rural Health Day. And this is, I think, is perfect way to celebrate National Rural Health Day with the projects such as this, screening for colorectal, breast, and cervical cancer. So again, thank you very much for this public service that you're offering for the entire West Texas.
Thank you. And Caroline and Kelly have been, great help to put this together. I know these things are not easy to do. to spread the word, get people to sign up. And so thank you very much. They've been, and I'm technically challenged, so they got it all cleared up very, very nicely. So I thank you for making me look like what I know what I'm doing.
Well, Dr. Romano, I'd just like to acknowledge, I think we have a question from Catherine early. Catherine?
I can't hear if somebody's talking.
Thank you very much. Now, can you hear?
Yes.
Yes.
Wonderful. I'm so sorry. I just, whenever I tried a couple of times to get to the evaluation and it just gives me an error message that it hasn't started yet. So I thought I might mention it in case I'm not the only one.
That I think is,
I will reach out to the CME office and let them know.
Okay. And
But
I can
just
turn into.
maybe
yeah,
it's because it's 12:45 and I don't know.
Okay.
maybe. Just keep that QR code handy or the numbers to text, and I'll reach out to them and tell them we're having some issues.
Oh, I can text you. Yes. Okay. Thank you so much for your help and for the
Thanks.
presentation.
Thank you.
And Catherine, if you have issues still, we could fix that. Just email us and we will handle it and make sure you get the appropriate, CME credits.
Great. Thank you. If I don't, it's okay too, but it's nice to have the certificate. Thank
Well,
you.
especially because it also has the ethics credit, which are not very usually available. So it's probably
Yes.
best to make sure you get it.
Thank you so much.
Then the other thing though is Kelly and Carolyn, let me know if I'm wrong, but we have this recorded as well. And so this should be available on our website.
Oh, that'll be great, actually. And if you could
Yes.
share that, then we'll blast it on all
Mm-hmm.
the things that kids do, like, I don't know, like Instagram or whatever. Like, is your all's generation do that. So we'll just make sure that it's available.
Yes, we will do that. As soon as it's available, I will share it with you.
Sure thing.
Well, it looks like we may not have any other questions. But thank you so much for your presentation.
Not a problem. I really hope that the word gets out and people, especially the medically underserved areas, is really where we need to hit hard in terms of making sure that those people get screened. And so since it will be recorded, that slide that had people's numbers and emails would be available in case somebody says, oh, I missed this, and so who do I call? So at least they'll have a route to reconnect with us for sure.
Yes, it definitely will. Well, thank you everyone for joining and have a great rest of your day.
All right, thank you.
Thank you. Bye.